Good morning, everyone joining us today in the audience and virtually. My name is Tsvet Turpkov, and I have the pleasure to introduce our grand round speaker this morning, Dr. Matthew Cheung. Dr. Cheung is originally from Winnipeg, where he completed his undergraduate and medical studies before coming to Calgary for internal medicine residency. Then went on to complete cardiology fellowship and an initial advanced echo fellowship at the Ottawa Heart Institute in Ottawa. Dr. Cheung is currently a fellow of advanced structural echocardiography at the Columbia University Icahn School of Medicine in New York. Now, Columbia is one of the busiest structural heart centers in the United States. So Dr. Cheung is getting a wealth of experience in interventions such as mitral valve edge-to-edge or mitral clip, tricuspid edge-to-edge repair procedures, atrial appendage occlusions, transcatheter valve replacements, and others. So the echocardiographer has become an integral member of the heart valve team. At Columbia, Dr. Cheung is getting invaluable training in this field. His mentor there is Dr. Rebecca Hahn, who is one of the leading experts in echocardiography in general, and in particular in the field of structural echocardiography, which is an emerging discipline. During my echo fellowship training, I have to say I definitely read many of Dr. Hahn's papers and guidelines. So Dr. Cheung is very fortunate to train directly with her. So I look forward to learning from Dr. Cheung this morning. I can say that we had a chance to get to know each other while he was an internal medicine resident here in Calgary. I attest that he was a pretty good tennis player at the time, but nowadays spends most of his time in the cath lab or the OR, having traded his tennis racket for a TEE probe. So I'll let you take it away, Dr. Cheung.
Thank you for the very, very warm introduction. And I just want to say it's my pleasure to accept this invitation to come speak with you this morning. It's been quite a while since I've actually stepped foot in a hospital in Calgary, but I'm excited to be back. And hopefully today I'll spend a little bit of time talking about what it is to be a structural interventional echocardiographer, using the mitral valve as a sort of lens to explore what it is that we actually do. These are my disclosures. So as a just brief overview, there's three major learning objectives that I hope to touch upon today. The first is to define the role of the interventional structural echocardiographer on a heart team and provide an introduction to the field of interventional echo imaging. Secondly is to review the peri-procedural echocardiographic and anatomical considerations for mitral valve interventions. And hopefully, if there's enough time, we'll go through some select clinical cases, mitral valve transcatheter edge-to-edge repair that may sort of highlight our sort of advantages in tertiary center. So what is the interventional structural echocardiographer? And in order to answer that question, we have to start with a broader look at what disease processes that we are actually tailored to address, and that is valvular heart disease, a disease that we know is becoming increasingly more recognized due to advances in detection, but also with a higher prevalence that is only expected to increase with an aging population. Just last year, the CCS working group on heart valve disease was created to sort of help address these concerns, and it's estimated that 2 to 3% of the Canadian population suffers from valvular heart disease. And by just, the year 2040, this is going to represent some 1.5 million Canadians, which shows just how tremendous of a problem it is for future Canadian cardiologists who are managing these patients. As a counterbalance to this increasing recognition and prevalence of valvular heart disease, efforts over the past several decades have focused on invasive, non-surgical approaches to treat these patients in our field, traditionally under the lens of a high to prohibitive surgical risk patient. With the obvious success of TAVR, which has definitely got a foothold here in Calgary, structural interventions have now evolved to start addressing more novel issues with transcatheter valve replacement sort of at the cutting edge of where we are today. And this was most recently highlighted with our TTVR sort of FDA approval with the Evoke device. Conceptually, this whole field, as you can see on the left here, touches on many, many cardiovascular related disease processes. And the term structural heart disease sort of encompasses all of this. That is to say that they're non-coronary, transcatheter-based interventional procedures aimed at these disease processes. And indeed, in order to keep up with this advanced technology, cardiac imaging, and in particular echocardiography, has had to come a long way. And today it is widely accepted that interventional echocardiography is crucial to the technical success of these complex procedures, the workhorse being 2D and cardiography. As I mentioned, so today, these structural heart interventions are mainly administered by Center of Excellence's multidisciplinary heart team, which was first pioneered actually at Columbia University during the partner trial era for TAVR. The heart team designation sort of allows for multiple cardiac specialists to review a patient's condition together and offer their recommendations for treatment. That is to say, is it conventional cardiac surgery or more novel interventional structural heart procedures or nothing at all? Integral to the heart team, the interventional structural echocardiographer serves as the main cardiac imager involved in the entirety of the patient's path of care. So you can see at the bottom there, we're heavily involved in patient selection, procedural planning, procedural guidance, and not only that, but the surveillance thereafter the procedure is performed. This point is so much so emphasized in multiple guidelines that you can see highlighted in the red here that the most recent iteration of the ACC valvular heart disease guidelines actually stress that all severe valvular heart disease patients should be being considered for intervention should be evaluated by a heart team whose integral members include a formalized position for an interventional structural echocardiographer. Historically, these interventional procedures were as I mentioned before, initially reserved for cases considered too high risk for surgery. But as these treatments sort of become more widely available and prevalent, a well-designed and coordinated heart team can help tailor treatment or no treatment to the individual patient on a case-by-case basis. And we actually have not great evidence, but real evidence that heart team model actually improves patient outcomes. So this is a retrospective cohort study performed in the Netherlands, which actually looked at mitral valve disease as a whole. And they took a general heart team from the earlier years, 2009, 2014, and compared that to a dedicated mitral heart team. So the general heart team consisted of a general cardiologist and a cardiac surgeon. And a dedicated mitral valve team consisted of an experienced mitral valve surgeon, so over 25 cases per year, an interventional cardiologist with expertise in transcatheter-based therapies, and an advanced structural imager, as defined by a minimum of 100 TEs annually, were included. And what they found was that not only did the dedicated mitral valve team result in more interventions, both surgery and transcatheter procedures that were offered to the patient, but regardless of that, the rate of non-treatment or just medical therapy at that point in time was pretty equal between both of them. And the overall one-year mortality in the general heart team was significantly higher in comparison with the dedicated heart team. So I've showed you a little bit about what is our importance as a member of the heart team and why a heart team is important. Now let's look at what it is that we actually do on it. So what is the interventional structural echocardiographer do best? Well, similar to conventional echocardiographers, have a finite amount of that we can do with a TEER. 5 probe manipulations, as you can see left there, and 5 imaging levels to image the heart through them. And this is no different than but incorporating an extensive combination of these maneuvers is super key for us in a rapid and efficient manner to allow for real-time imaging. And that really is what distinguishes cardiographer. I think it's also important to stress that maintaining on-axial imaging is super during procedures to allow for 3D guidance. And we'll touch on that a little bit more. But these are the sort of main maneuvers that I deal with on a day-to-day. One of the major tools that we heavily rely on in the structural interventional echocardiography field, comprehensive understanding of 3D technical principles, and the different strengths and weaknesses of various 3D techniques. So here I've just illustrated sort of the plethora of 3D techniques that we have. In the top left-hand corner, this is a 3D zoom model and a surgeon's view as well as a bottom view of the mitral valve apparatus. In the top right corner, we can see MPR live that gives us various visualization and a 3D model in the bottom right-hand corner. We also have sort of full volume and 3D live capabilities with color shown in the bottom left-hand corner. In the middle is a 3D full volume clip of the LV here as well. And then finally, in the bottom right-hand corner, we have live 3D as well. Now, all of these can be ECG gated to improve spatial and temporal resolution with multi-beat acquisition. But really, this is the workhorse of what we do in structural echo. And increasingly important, actually, is also a mastery of these skills also allows us to better quantitate valvular heart disease as a whole. So currently, I can't think of a better exemplification of the role of the structural interventional echocardiographer than looking through the lens of mitral valve regurgitation. And so here we sort of see the ACC 2020 focused update on the management of MR, and front and center in the patient's path of care is the cardiac imager that's really well defined in these graphs here. And so hopefully we'll follow this model and go through mitral. Show you guys what it is I actually do. Now, as we know, mitral valve disease is one of the most complex and heterogeneous pathologies in cardiovascular medicine. And with the development of these new devices and approaches for managing patients with mitral valve pathology, the heart team decision-making approach to manage this pathology is even more warranted. Just as a refresher of mitral valve anatomy, for those not sort of comfortable with it, we can remind ourselves that the mitral valve itself refers to a complex structure with multiple components that include the left atrium, the mitral valve annulus, the leaflets, the commissures, the chordae tendineae, the pap muscles, and the LV. Now, dysfunction in any one of these components can lead to MR, and the assessment of all these components is actually crucial to the screening process for potential candidacy for transcatheter-based mitral valve interventions. Just two major anatomical points that I'd like to emphasize with you guys today is the actual importance of the mitral valve annulus. So it's commonly described in textbooks having this saddle-shaped morphology on gross specimens. But when we actually image it on 3D, being CT or TEE, it's actually more of a D-shaped structure with the anterior portion sort of defined by the anterior mitral valve and the aortomitral curtain. That's at a different level than the aortic annular level. The integrity of this annulus is hugely important in the pathophysiological mechanisms of MR, as I'm sure our surgeons are aware of the sort of annuloplasty reducing effect that we sort of talk about and when we talk about interventions on the mitral valve. And secondly, by convention, the mitral valve is based on the surgeon's view. So if we look at the bottom right-hand live image here, we can sort of see that moving from left to right, we have the sort of lateral scallops, sort of called. In the middle, we have the middle scallops. And then finally, on the right-hand side, we have A3P3, or the so-called medial scallops. We should note that, however, the anterior leaflet doesn't actually have these true scallops, but the scallops are actually anatomically labeled based on its relative relationship to the posterior mitral valve, which actually has these better defined leaflet scallops. The many potential causes of MR are historically broadly categorized by the leaflet motion abnormality proposed by Carpentier, who by trade was a surgeon, and whose initial goal was to sort of categorize MR by its leaflet motion to better define how to surgically correct this disease. But more contemporary classifications of MR have sort of focused on a more practical classification based on primary or degenerative MR caused by intrinsic disease of the mitral valve, as opposed to secondary or functional MR, which is primarily driven by disease processes of the left ventricle or mitral valve annulus. The superimposition of these two classification systems can be somewhat confusing for the uninitiated. So for primary MR, you can have Carpentier 1 in the setting of normal leaflet motion, as in a leaflet perforation. But you can also have type 2 as a primary MR, in which there's like Barlow's or very myxomatous mitral valves. And finally, you can actually have 3A as well in the setting of rheumatic valve disease. So I think a more easier to understand approach would be that distinction between primary and secondary MR. And most of the trials and devices are based on this. Just to illustrate how echo techniques really imitate the real life surgical models here, I've displayed sort of from a textbook, the surgical sort of various Carpentier classifications, and to the left-hand images, the corresponding 3D echo images that we see. So in the top left-hand corner in figure A, we can actually see this is a type 1 Carpentier with relatively normal leaflets and severe annular dilatation, so a functional sort of cause of MR. In the panel to its right, in the B, we see excessive leaflet motion that is really characteristic of severe myxomatous mitral valve disease. The bottom left-hand corner, we have restricted motion of the mitral valve leaflets in systole and diastole, and that classic sort of fish mouth deformity that we talk about for rheumatic heart disease. And finally, in the D right now, but the ischemic mitral valve and severe tethering of the posterior leaflet, almost not seen at the bottom at 6 o'clock there. So how do we sort of address these with our transcatheter-based therapies? So the story sort of goes, if you look back at the 1990s, a surgeon by the name of Otto Alfieri sort of planning a mitral valve case for a young woman with sort of horrendous anterior mitral valve prolapse-related disease. Really, the surgical techniques at the time were not conducive to repairing her valve. And it was actually thought, would she benefit from a mitral valve replacement? But being young, those options aren't great. And being of child rearing age, warfarin or a mechanical valve really wasn't in her best interest. As the legend goes, or by happenstance, Dr. Alfieri's morning case actually happened to be an ASD closure of a double orifice mitral valve. And what he noticed in that case was that, despite there being this significant tissue bridge in a double orifice mitral valve, there was no significant stenosis and there was no significant regurgitation. And that really is what inspired him to create the Alfieri stitch that we know here. So in the top right-hand top row there, you can see this is a congenital double orifice mitral valve. And then on the bottom row, you can sort of see Alfieri's work that he sort of pioneered in the Alfieri stitch. And he got a great technical result for the patient, and the patient went on to successfully have a child and did great after her operation. So Alfieri's discovery, sort of in the years thereafter, pioneers in the field realized, hey, this technique's actually probably better suited for transcatheter-based techniques. And so the work had already been in motion for mitral transcatheter edge-to-edge repair was sort of born out of this. Here, a very brief overview of the procedure is shown. So first, the left heart is accessed by a venous access, and a transseptal puncture is performed, which creates a communication between the right atrium and the left atrium. And thereafter, we can introduce our clip delivery system. And it takes some maneuvering, but we're eventually able to get all our gear into the left side of the heart. Once the clip is successfully sort of extruded into the left atrium, the hard work begins, and we start to guide down our clip delivery system down towards the mitral valve with the ultimate goal of approximating anterior and posterior mitral valve leaflets together and improving overall coaptation of the mitral valve. This is sort of done by wedging a healthy amount of leaflet tissue into the very crux of the device. And then there's frictional elements on the device that close along with the clip And this has the added benefit of sort of approximating the annular dimension, as I sort of alluded to earlier, is a very important mechanism of MR. At the end, we're sort of left with a secured tissue bridge between the anterior and posterior leaflet, and hopefully have caused a meaningful reduction in MR at the expense of reducing the mitral valve area or inducing mitral. So what do the guidelines say about this procedure that we offer? Well, despite an increasing attention to the importance of valvular heart disease and recognition of the impact of MR, therapeutic management of valvular heart disease as a whole still remains sort of an open issue. You know, there's open-ended questions about the optimal timing of intervention, the type of intervention, repair or replacement, and the modality of or technique, including surgical or interventional. In reviewing the guidelines on this topic, multiple societies are clear in some regards and then remain vague in other areas. So I don't think any practicing cardiologist would sort of argue that primary MR that is severe and symptomatic should quite unanimously undergo a surgical route, barring any prohibitive surgical risk. And I also think that there's probably widespread agreement that symptomatic severe secondary MR requires exhaustive heart failure optimization and maximization of GDMT. But outside of those two extremes, I think there's a lot of gray area when it comes to intervention that needs to be tailored to the patient. So here are on the left-hand side, just showing the transcatheter baseline recommendations from the ACC, and to the right, we see the ESC sort of recommendation. And those recommendations vary from a 2A to a 2B. However, I think a more practical approach for the clinician at the bedside is actually this lovely figure here that just simply separates it into symptomatic severe primary MR and symptomatic severe secondary MR. And you can see rate limiting step of both those algorithms is a heart team assessment. Thereafter, you know, if we're dealing with primary, you're looking for every reason to send this patient for surgery. And if that's not the case, then you can explore edge-to-edge repair as a possibility, or if the anatomy or the patient, medical. And on the right-hand side, we'll touch briefly on what it is to be coapt-like, but essentially you're looking for prime candidates who would benefit the most or derive the most benefit from mitral TEER. So just, of course, no talk on mitral valve TEER would be complete without at least mentioning the contentious debate between the utility of TEER, functional MR, and the marked trials of COAPT and MITRA FR. So I really don't want, this isn't the purpose of my talk, but no talk would be complete without at least touching on it. And I think the important points for people to take away is that COAPT is sort of the only trial that has shown a prognostic benefit of mitral clip implantation compared with conservative or medical management. And MITRA FR was essentially a negative trial. And there's been a lot of sort of thought generation around what the discrepancy is between these two patients. But I think the take-home message is that the right patient has to be selected in order to benefit from this. And what does that mean? Well, it means that the patient with MR, functional MR, shouldn't have any sort of too far gone sequelae of significant MR. And that means, no evidence of severe LV remodeling. That is, their EF is too low or too dilated, that they have no right-sided complications. That means RV dysfunction, significant TR, markedly elevated pulmonary pressures, and not obviously on any advanced therapies, including vasoactives or mechanicals. Here's a nice European study, which essentially looked at creating a COAPT-like profile and those patients undergoing TEER. And we can see that there was definitely a benefit at both the 2-year and 5-year mark if the right patient was selected. So a closer look at the most popular devices currently available, the MitraClip G4 clip delivery system sort of represents a culmination of the 4th generation of these MitraClip devices since its first in. The device itself is a very straightforward design with a clip frame and clip arms that consist of cobalt chromium, and that confers a really stiff and rigid quality to the device. On the top right-hand side, you see the main components are these sort of clip arms that extend out, as well as the associated grippers that have frictional elements on it. So here we see 6, which is common for the XT or the XTW. And on the smaller NT and NTW devices, there's 4 rows of these frictional elements. We talk about selecting the right clip for the right patient, and there's a lot of anatomical consideration that goes into that. But very briefly and very broadly, I just want to go through some of those considerations that we think of as structural echocardiographers. One is leaflet length. So in general, a shorter leaflet length of the mitral valve would confer a shorter device. That is the NT or NTW. The second is jet width. So broader jets, obviously we want a broader clip. And so we're geared more towards the W type devices, either the N. And then finally, the starting mitral valve area. As I mentioned, it's a fine balance between mitral stenosis and mitral. So if you're obviously starting with a smaller mitral valve area, you want to select less. I think super important to securing this is really understanding the engineering and design of the device thoroughly. And so the elements of the mitral clip device that I think are important. The first one is that it works with an active locking mechanism. So, these frictional elements, along with the grippers, actively bite down and sequester leaflet tissue. Pascal. And these frictional elements are located on both grippers and tended to drop along the atrial aspect of the mitral valve leaflets. These essentially provide the force and the tension necessary on the leaflets, and it's a graded process. So the closing forces that are present on these each individual time, while it does exist, the most force that is put on the clip is actually at the innermost, which is why it's so important for us to get leaflet tissue at the innermost edge of it. The other thing you'll notice, though, is super important, as the image on the right shows that, if you have really, really thick leaflets, it's really hard for that clip arm to close completely and secure all the frictional elements. So, a really good assessment of leaflet morphology is super important. As an alternative to the mitral clip device, I'll just spend a little bit of time talking about the Pascal device, which is actually approved in Canada. So in contrast to the mitral clip design, this is just another iteration. It's sort of the new kid on the block. So it has a lot of engineering built into it, in which practitioners struggled with the mitral clip that addressed, and these designs are sort of reflected in that. So it's a nitinol-based structure, actually works by passive fixation. And so nitinol is a material that it will always try to conform back to the shape that it was. So it really, if you notice, there's not really any frictional elements. There's these grasping zones, but it really works by passive fixation. Secondly, there's a central spacer in the larger Pascal device, in which it allows to fill the gap of the mitral valve. And this can help us in approximating leaflet tissue. And finally, the main advantage is more for our structural counterparts, but this device is extremely device. And so it can elongate, help us get through very tortuous sort of chordal tissue. Just the steerability of the device is much better than the mitral clip itself. Sort of the complementary aspect of appropriate device selection is, of course, the anatomical suitability of the mitral valve. And so, this is a figure by Hausleiter, which has a really state-of-the-art mitral TEER, which I encourage people who are interested to have a look at. But essentially, when we're assessing anatomical suitability, there's sort of 4 main considerations that I think of. First and foremost is mitral stenosis. So we have to understand that transcatheter edge-to-edge repair is fundamentally a procedure that trades off MR for MS, and striking that balance between the two what is crucial for us to have good procedural success. Secondly is how likely is it that we're able to optimally reduce the degree of MR? So if there's lots of complex jets, multiple jets in weird locations, it's going to be quite difficult for us to get a good result with simply one. Leaflet integrity is super important. So as I mentioned, with a MitraClip device, a device that relies on active fixation, the structural integrity of the leaflets is super important in order to minimize leaflet injury. And finally, is there any potholes or roadblocks to deployment of the actual device? So is there enough transeptal height for us to cross from the right atrium into the left atrium? Or is there any, complex subvalvular cords that when we're bringing our device underneath, that we're going to get entangled in and limit proper deployment of the device? Here, so this is what I sort of deal with on a day-to-day basis, and these are just like some examples of probably suboptimal anatomical suitability. So in the top left, calcium on the leaflets, obviously an issue when you're trying to short posterior leaflet, just really can't grab that tissue. If there's a perforation of the leaflet, obviously it's going to be very challenging for us to close that MR with a clip alone. And then most of the other ones that we see here are considerations of mitral valve areas. So mitral valve area, mitral annular calcification, which contributes to stenosis. These are all considerations for us. In the bottom right-hand corner, we can see these sort of cleft-like indentations, which I would say that most people or practicing clinicians who see this would think nothing of it, but for the structuralist, it's super important to know where these indentations are, because when we're clipping the mitral valve leaflets together, we can actually open up more MR in these cleft-like indentations and actually very quickly, I would just wanted to show you the spectrum of disease that we have and how we image it. So these, each row represents a different sort of mitral valve regurgitation and valve itself. And you can see the wide spectrum of how broad these jets are. So all of MR, but their jets are obviously very different. So in the top right, we see a lateral P1 flail with this sort of deep, broad MR jet that's eccentric. In the middle here, we actually see the same sort of flail type mechanism, but this time on the medial slide. And this is a super highly eccentric jet that comes right across the face of the mitral valve annulus. And finally, in the bottom right there, we see a flail of the actual entire mitral valve leaflet. And apologies that the cycling. Okay, so that was a lot about mitral valve transcatheter edge-to-edge repair, and I want to spend the last sort of several minutes of the talk just going through some real-life cases that I've seen at Columbia. So the first one, 85-year-old gentleman, he's got NYHE3 dyspnea and has frequent exacerbations of heart failure. He's also known for coronary artery disease and paroxysmal AFib. And he's found to have severe MR and so referred appropriately to a heart team setting. He's seen by cardiac surgery, and they calculate his STS to be sort of in the intermediate range, but really not captured is his frailty, age, and so overall he's given sort of high to prohibitive risks. So a transcatheter-based technique is sort of offered to him. This is his baseline imaging, and despite all those techniques I told you about, imaging of these real-life patients can be challenging, especially when they're on the table cath lab or in the hybrid OR. So here we're not quite on axis, but one of the techniques we've developed is actually to use an intravenous pressure bag of saline, and we put that under the patient's right shoulder and lateral decubitus, and we can get. And here, I don't think there's any doubt that severe MR is shown here with reversal in the pulmonary veins and a posteriorly directed jet consistent with anterior pathology. The 3D's a little bit more telling here. So we actually see there's prolapse and actually focal flail of the anterior A2 scallop with ruptured cord there. Sign that we see on 3D. And then, the posterior leaflet is short and tethered, but it's not prohibitive. And then we actually plane emitter the mitral valve before we start the case, and we're getting a good mitral valve area of about 6. the baseline color. And as I mentioned, 3D is so tremendously helpful in us quantifying mitral regurgitation. So here we've done MPR processing and actually calculate a vena contracta area of about 0.88. So calculate a regurgitant volume as well, which happens to be 160. So just to summarize the considerations of the structural echocardiographer, we sort of take in the mechanism, the leaflet health, the imaging windows, and what potential barriers, and using house lighters, sort of that diagram I showed you, I sort of classify these things into what I think are green light, yellow light, and red light mean prohibitive. So this case, by and large, pretty straightforward case with green lights, a couple of yellow lights, but that should be no big challenge for us. So we actually selected a Pascal ACE implant. And the reason being, the anterior mitral valve is obviously quite myxomatous, but the posterior being quite short. The Pascal device, sort of with the passive locking mechanism, a little bit gentler on the leaflets, thought that would be a good fit. Look at guiding. So these are images actually taken directly from the case. So again, we're using 3D MPR to perform the transeptal puncture. For central MR jets, we try to go for a posterior and slightly superior transeptal puncture. Higher heights may be needed depending on the location of the jet. So the more medial the jet, because your device has to sort of wrap around and curl, we generally want a little bit more height on the transeptals. But this case, it should be no issue. And then, of course, 3D manipulations, once we're bringing the device up, you can see it in the left atrium in the sort of middle panel there. And to the right, we can see that there's the clip is sort of being brought down from the LA as we're trying to orient the trajectory and place the clip at sort of 12 to 6 o'clock that you'll sort of see in the bottom right-hand figure there. Moving forward, so sort of the left-hand clip sort of shows us we're now advancing the device into the left ventricular while maintaining our device trajectory. We want to be sort of perpendicular to the commissural line, and we'll do that by orienting the clip arms. In the middle there, you'll see actual leaflet grasping. So the grippers have actually been dropped down onto the clips. And we see good interaction of the device with the leaflets. And one last check of the MR to make sure, yes, we're on top of the MR jet, and this is where our final location will be. And this is usually guided under 2D biplane. And the reason for that is just a higher sort of temporal and spatial resolution as compared. Not to say that 3D can't do this, but 2D is generally probably most preferred. Finally, on the left here, we see actual deployment of the device where we disengage the clip delivery system. And then the images to the right actually sort of show that, yes, the clip is secure. There's a nice tissue bridge, and we've created that double orifice that we sort of saw in previous slides. Post-procedural assessment for us is also super important. So we do lots and lots of checks to see what the actual pre and post are. So we check gradients across the valve, check for pulmonary veins to ensure that that reversal has back to sort of normal flow. We have to assess the transeptal puncture to make sure that there's no significant right to left shunting through the hole that we've created between the two septum, the two atrium. And finally, we want to make sure, again, striking that balance between mitral stenosis and mitral regurgitation, we calculate a mitral valve area. And I think the results speak for themselves. So even if you are not familiar with looking at echocardiographic sort of mitral valve assessment, on the top there, we see what we started with. And on the bottom, we see what we're left with. The degree of color is the mitral regurgitation. And we can see we got an excellent result by reducing that MR. And that patient did extremely well. And it was actually NYHA 1. I'll just skip over this, but just more post-processing imaging that we do after, just to ensure that the mitral valve. Very quickly here is our second and final case that I'll talk about. So this is a 60-year-old female with no cardiomyopathy, previous bypass surgery, who presented with chest pain and cardiogenic shock. Despite her angiogram showing patent grafts and diffuse and atherosclerotic disease, she was still in early shock and was managed with an IABP and vasoactive agents, and subsequently found to have severe mitral regurgitation. She spent quite a bit of time in the CCU, and despite sort of optimization of her volume status, vasoactives, really unable to wean off her advanced therapies. And so our heart team was asked to comment or see if any sort of bailout mitral transcatheter mitral valve therapies could be offered to her on day 19. Here, we're dealing with a functional mechanism of MR, and I just wanted to highlight with this case that, not all functional MR is just straight up A2P2, but here we actually see two jets located on either side of A2P2. There's restriction of the leaflets, and the leaflets are definitely tethered down. And to someone who is looking at this just haphazardly, you might say, yeah, that's probably like moderate MR. But that's one of those things that we do really well, is actually full quantitation. So if you notice in the top right, there's definitely pulmonary vein reversal. Our suspicion is quite high that there is significant MR. And so we don't use color alone. We actually use multiple techniques to sort of ascertain the actual severity of the MR. And one of the methods that not a lot of labs do is continuity equation for actually sorting out what is severe MR, what is moderate MR, and would the patient benefit from an intervention. And so here briefly, these are the measurements that are required to adequately quantitate by continuous Doppler, by Doppler method, or continuity method, sorry, of the MR. And as it turns out, it was severe MR. This is our baseline sort of mitral valve morphology and anatomy that's shown here. So the images to the left and right are the same, just different views, variations on the theme. Sometimes changing how they look helps us visualize it a little bit better. We can see in the top right-hand corner that mitral valve area is not as robust as our previous example. So we're starting in the mid-5s, but we should keep in mind that 5, based on how the jets are shown, we're probably going to use a 2-clip strategy here just because there's 2 jets. Our pre-imaging, and you can see again those 2 jets that are going to give us issues here. And again, we can quantitate that by 3D VCA. And so as comparison to the first case I show you, clinically, this is a red flag, right? This patient is super, super sick on IABP, hasn't been able to get out of CCU for nearly 3 weeks. So we're not starting from, the outpatient that's coming in with some severe symptomatic MR. In terms of looking at the mechanism, we got multiple MR jets. There's probably, ischemic tethering. There's also ventricular functional, in which the leaflets are being tied down. And the valve area, while good, we know that we're probably going to have to use a 2-clip strategy. And so we want as much valve area as we can. And, that traditional sort of number that we think in our head is probably going to have to be a little bit higher. And so I'd like to see that mitral valve area a little bit more robust than 5. So we'll see what we get. Another challenge that I didn't sort of show you was that the interatrial septal height is very low. So just simply getting our gear across and getting it down to the mitral valve is going to be tremendously difficult when we're only working with the septal height of 2.8. So what device did we actually choose? We chose NT based on the restriction of the leaflets. We know we're going to have to use a 2-clip strategy. And so anything to preserve mitral valve area is going to be crucial to having good success. Transeptal puncture coming through. And I just want to show you how we can image this. So you can do this on biplane, you can do this on single. Our preferred method is actually 3D MPR. That's our sort of workhorse there. Here, we're grasping our first clip. So we're going after the most medial jet here. And so on the right, we can see that we're trying to lay those leaflets on top of the clips before dropping the grippers. And then the images to the right and left are showing just before we drop the clip arm and after. So we are indeed right on the jet, and we can see actually a total obliteration of that medial MR jet. Pretty happy with where we are there. With our second clip, we then go to the more lateral jet, and same thing here. On the image to the left, you can see we've actually dropped our glippers. We're seeing tremendous sort of interaction of the device with the actual leaflets, which tells us that we, got enough leaflet down into the clips and that we're confident that we're going to form a secure tissue bridge. And then the images to the right and left here sort of showed that, yes, we are able to get significant reduction in the MR, and our clip device is where we want it to be. And so again, just a side-by-side comparison. On the top, you can see our pre-procedural imaging where we started off with, and on our bottom, we can see post. And again, even to the untrained eye, I think you can really appreciate that we got a really excellent reduction in the degree of MR. And as opposed to the first case, we have this triple orifice because we put two devices and sort of made an A-frame of the either side of the A2P2 interface. Obviously, we knew that mitral valve area was going to be a concern here. And indeed, we're left with a mitral valve area of about 1.6, so less than desirable. We generally shoot for a valve area above 2, if at all possible. But I think given the patient's clinical scenario, this is a pretty good outcome. And these are the different methods of showing that post-procedural, the degree of MS is acceptable. And so just to sort of wrap up, the patient was quickly weaned off IABP within 24 hours after the clip procedure, off vasoactives in 72 hours. And we're not saying that this is the definitive therapy for her by no stretch of the imagination, but she was able to follow up with heart failure and be referred for advanced therapies thereafter. But the main thing is, stabilizing the patient, getting her to a place where she can be adequately assessed by the heart failure service. So hopefully I've impressed upon you the importance of the cardiac imager as part of a Center of Excellence heart team and our important role in that. And with that, I'd be happy to take any questions or comments. Thank you very much.
Thank you for the great talk, Dr. Cheung. So maybe I'll start because I've got the podium. So I think a fascinating area in cardiology, certainly one where we're seeing a tremendous amount of real advances, technological innovations. We're at one of the cutting edge centers. I'd ask you, can you speculate on what are the next big things in the field of structural echocardiography with regard to device innovations or imaging innovations such as FRCPC, echo fusion, or intracardiac?
Thank you. So the question was related to where I see this field advancing. And I think, one of the major draws for me to pursue this fellowship was that I see it as the leading edge of cardiology. It's sort of where angiography was many decades ago, and that, a lot of industry and a lot of brilliant minds are in this field, and it's changing every day. To me, I think that the devices, while edge-to-edge repair, we've known it to be safe and effective, but I think that there are many gaps in treatment for patients who suffer from horrendous tricuspid regurgitation and mitral regurgitation. And I really think the field is directing towards transcatheter valve replacement as opposed to repair. And so I think that's where it is. Sort of mentioned, really exciting that the Evoke device got FDA approval sort of last month. And so I think it remains to be seen, but I think when we look back at in many years, that the valve replacement transcatheter in the right patient will prove durable and have excellent outcomes. And then with regards to imaging, I think fusion imaging, as you mentioned, so the hybridization of FRCPC as well as echocardiography really helps our team. So, what I didn't really comment on is our counterparts we work sort of like left hand, right hand together is the structural interventionalist. And so having a complementary modality where we can fuse both the fluoroscopy that they rely on and the echocardiography that we use combining those two will definitely be beneficial moving. Not routinely, but I would say for difficult transeptal punctures, we found it very impressive. We're also sort of experimenting with holocron imaging, which is essentially this massive device that the interventionalist is able to wear, and it sort of 3D orients where the clip is going. So there's, a lot of industry and a lot of efforts being put into how best to portray these information, because we know how important imaging is to having procedural success for these novel procedures.
Questions, Dr. Kaplan?
Okay, once the clip is deployed, okay, let's say you're not happy with the result, can you take it out and reposition it? And what about down the road, say in a year, that they develop more MS than a regurg? Can you then remove that clip and redeploy?
So that's an excellent question. Thank you. So the question was, once the clip is deployed, can it be retrieved? Or further down the road, if we do notice that there's significant mitral stenosis that the patient is left with, is there any possibility of device retrieval at a later date? And so currently, I would say no. And that's why it is so important to have a good imager and really make sure that you're happy before you let those strings go and that the clip is there. There have been some for device retrieval. I haven't sort of seen any device retrievals and you're sort of stuck with it. I will say that most of these patients without the clip would have been going for surgery anyways. So if that is the case, surgery is sort of where. But there are very cavalier structural interventionalists that have done, years out, if they're left with significant mitral stenosis, they have put other devices in between those orifices to make it bigger. So that has been well documented in case reports. But the tissue bridge that is actually made after the clip is employed is there's actually endothelialization of the device, and it really becomes a tissue bridge. So it's not an easy thing to yank out. Yeah. No, in general, no. Unless they develop atrial fibrillation or something like that, as opposed to, a valve-in-valve device, or if we put a valve replacement within MAC or mitral annular calcification, those we generally prefer to anticoagulate them, but for the mitral clip itself, no anticoagulation is required. Yes, it has. So the triluminate is the main trial, and then there's the ongoing sort of class trial for the Pascal device on the tricuspid side, which Dr. Hahn was actually.
Right. There's another group that has the room at 9.
Right. Well, I'd like to thank Dr. Cheung for making the trip from New York to visit us and give us an excellent lecture this morning. And I'll wish everyone a good rest of your day. So thank you so much for tuning in.